Good afternoon and happy Friday. I'm Maggie and I'm here with Dr. Dan Ciccato, our Chief of Staff at Scottish Rite Hospital. We're here to talk with you today about scoliosis in honor of Scoliosis Awareness Month. So let's get started. What is scoliosis, Dr. Ciccato, and how do we screen for it?
So first, thank you for the introduction. We're excited to do this Facebook Live on scoliosis because this is Scoliosis Awareness Month, June. So scoliosis is a curvature of the spine. It's most easily recognized on an x-ray where you have a left to right shift of the spine. With that right to left shift, there's also some rotational aspect to the scoliosis that you see on patients. And so we screen for scoliosis by looking at patients, analyzing patients, and doing a physical exam. And that's done in the school, it's done in the pediatrician's office, it's done here. And the simple test is they stand with their legs shoulder width apart. They bend forward in a very relaxed fashion, let their arms dangle in front of them. And then we look to see what the spine looks like and what the ribs look like, and to see if there's any rotational aspects to their spine that are asymmetric. And because that's the first thing that you see with scoliosis. And it's a nice screening test. And the pediatricians, the school nurses do it, and we do that here.
Okay, so then if a kid at school needs to come get further attention by a specialist, what happens when they come to Scottish Rite Hospital?
So they can get referred directly from the school nurse, or they can go through the pediatrician's office, or the mom or dad can call and get an appointment. And so when they come here, the first thing that happens is we get a good history. What are they having any back issues? Do they have any underlying conditions? And then we do a physical exam, a good physical exam that looks for scoliosis. We do a good neurologic examination also. If it looks as if they may have scoliosis, then they'll get an x-ray. And we're fortunate here to have this system called the EOS system, which we've had for almost 2 years now. That's really state-of-the-art technology that allows us to get a full-length film looking from the back and from the side with very, very low radiation. And we can also make a three-dimensional image of that spine if we need to.
So then in that EOS system, what are you looking for? What is it that would be a big red flag for someone with scoliosis?
Yeah, so what we look for is to see if there's this lateral curvature of the spine. You'll see, instead of the spine being perfectly straight, you'll see a deviation from the midline. It can be in the thoracic spine, it can be in the lumbar spine, it can be in both. And then what we do is we look to see what is the measurement of that scoliosis. It can be a very mild scoliosis or it can be a very large scoliosis. And depending on the magnitude, depending on the age of the child, depending on the type of scoliosis it is, then we start to make some treatment plans or observation plans depending on a number of different factors.
So then, is it more common in females, males? Is there a common age that scoliosis kind of appears, or?
So the first part is the diagnosis of scoliosis, and there's many types, which you're alluding to. And so the most common type of scoliosis we see is adolescent, if you're older than 10. Idiopathic scoliosis means we're not smart enough to tell you why you have it. The bones all look normal, they're otherwise a healthy, normal child. So adolescent idiopathic scoliosis. So in that particular diagnosis, it's more common in girls. Larger curves are more common in girls than boys. And we use their age, in girls, we tend to figure out where they are in their growth, and boys, because scoliosis gets bigger in two main ways. One is if you're growing fast, and the second is if the curve measures above a certain magnitude. So we measure curves in degrees. A straight spine is 0 degrees. Anything above 10 degrees is true scoliosis. And curves above 50 degrees will get bigger very slowly, but will get bigger over time, even if you're done growing.
Okay, so then you talked about the different types of scoliosis. What else? What other types are there than AIS?
So within idiopathic scoliosis, there's younger children who have scoliosis. So there's infantile scoliosis, so those are patients 3 years or less, so newborns to 3. That's less common. Juvenile scoliosis is from 4 to 10. And for those patients, those are a little bit more challenging because they have a lot more growth left, and so the curve can get bigger. So there's a little bit different treatments that we do. So for example, for infantile idiopathic scoliosis, we try to grow the spine straight with non-operative treatment, with casting as an example. Sometimes those infantile idiopathic scoliosis curves get bigger on their own, but if they don't, then casting is a great technique that we've used here. It's called the META technique, and we had META come and visit us about 10 years ago and show us the technique, and it's worked really well at this institution. So outside of idiopathic scoliosis, many syndromes, many conditions, you can have scoliosis. There's also congenital scoliosis, where you're born with an abnormally shaped vertebra or several vertebrae that will create scoliosis. So there's a number of types of scoliosis, but again, the most common is idiopathic scoliosis. But we certainly want to make sure that patients don't have the other types because the diagnosis is really important from the outset.
Good information. So I think we're going to get into some of the questions that our followers posted yesterday from our promo. So one of the first questions is, what degree of curvature begins causing pain and problems for the individual?
So generally speaking, in children, adolescents, curved scoliosis in general doesn't cause pain, or at least we don't think so. One of the largest studies was done here at this institution about 20 years ago by Charlie Johnston and one of our fellows at the time, and they looked at over 3,000 children, and about 30% of them had back pain. But if you poll otherwise same-aged children, that they're going to about the same incidence will have back pain. So curve magnitude, generally speaking, is not an indication that they have back pain. We get concerned about curves above 70 and 80 degrees because potentially as an adult they may have back pain. That also may affect their pulmonary function as they get older. So those are the curve magnitudes that are very large that we tend to treat fairly aggressively.
So then does this, for kids who are growing up, they're obviously probably into sports and activities, so does that at all inhibit them from participating?
So if they have scoliosis, there's no curve magnitude or type of scoliosis that really prevents them from being active. If they have larger curves and they need treatment, treatments can be for scoliosis, typically for idiopathic scoliosis, we observe smaller curves, or curves that are a little bit bigger in children who are essentially slowing down on the growth. We have bracing, and bracing is a very effective tool. It's a very effective treatment. And fortunately here at Scottish Rite Hospital we have our own orthotics department, and so there's an orthotist in each of the surgeon's clinics, and so we talk about those patients who we think need a brace. We talk about what type of brace, we talk about which curves we're going to strategically go after in terms of the bracing. We have lots of studies that have been done here in terms of bracing, and we use a lot of different techniques to make sure the brace is very effective, including placing a temperature sensor in the brace to sort of see how often the children are wearing the brace. So bracing is oftentimes utilized. And then surgery is just for those children who have very large curves that need some correction with their curve. Now, once they're done with their surgery, kids get back to doing all activities. We let them get back to doing full activities, whether that's sports, dance, PE, and those sort of things. When they're being treated with their brace, they come out of the brace to participate in sports. So it doesn't slow down their activities. We certainly want children to be active and busy, and this doesn't put them at any risk for having any issues with respect to the back.
That's awesome. So then for after they're out of their brace or whatever the treatment may be, is there some sort of physical therapy that they go through or chiropractic care or anything like that?
So generally speaking, we have not used physical therapy as a method for treating scoliosis. Now, I will say that there's something called scoliosis-specific exercise programs, which have become taken on greater popularity. They've been around for a long time. The most popular is called the Schroff method. This was a method that was developed in Europe, and we have 3 trained therapists in Schroff method. And actually, we're leading a study, international study for the Schroff method here, and we're the primary institution, but there's several institutions throughout the country, actually, that are participating in the study. So physical therapy can be used for smaller curves. We're testing it, we're seeing it, we're studying it. So it can be used. If patients have back pain, we have a great physical therapy team here that will show them very good exercises, very straightforward exercises that are very effective for taking care of the back pain. And then chiropractic medicine is a question that often comes up, and there's no literature to support chiropractic treatment of the scoliosis, in other words, to treat the scoliosis itself. But we certainly are open to the issue and the fact that many patients get benefit from chiropractic medicine with respect to their back pain. And so if families want to do that, and it's effective for them, that's great. But to treat the scoliosis is not really appropriate. And so they should definitely seek medical treatment for the scoliosis.
Okay. Next question is talking about, do you experience hip issues later on in life after having surgery?
So surgery, the goal of surgery is to do two things. One is to prevent the curve from getting any bigger, and the second is to correct the curve a certain amount. And today we are very we have better ways and strategies intraoperatively of gaining better correction, fusing less levels in some instances. So we try to limit as much on the number of levels of the spine that we operate. And so in your spine you have roughly 30 vertebrae, and so we try to limit as best we can, because in the end, although we correct the spine, we fuse those segments of the spine that we're operating on. So that puts some stress on the remaining levels of the spine, and it can put some stress on the hips. But generally speaking, patients who have scoliosis surgery do very well with their hips, and they just need to keep their back in good shape, do good core exercises, stay thin, stay as well conditioned as they can. And generally, patients do very, very well. We don't have 50-year follow-up on patients who've had scoliosis surgery, but we certainly have 20-year follow-up from some very nice work that was done in Sweden that suggests that patients do very, very well in the long term with scoliosis surgery.
Wow, that's awesome. So next question, can spines revert back after non-invasive treatment, and how often, if so, if they do?
So the non-invasive treatment in general today, traditionally, and the standard of care is really bracing. And so for bracing, the goal of bracing is to prevent the curve from getting any bigger. And so if we brace a child who has a 25 to 30 degree curve, for example, and they're still growing, the goal is to prevent that curve from getting any bigger and to keep that curve at that magnitude. And a 25 or 30 degree curve, if they're skeletally mature, done growing, that curve shouldn't progress over time, and that patient should do very, very well. Now, can curves slowly progress and sort of break the rules over time? It's certainly possible, but generally speaking, there have been very good studies that have shown if your curve is under 45 and certainly 50 degrees and certainly 45 degrees, and you're done growing, that curve should not progress into adulthood.
Okay. Would you ever recommend bracing a congenital curve to allow for more time of growth?
The traditional answer is that bracing is not effective for congenital curves. So let's say in a patient, instead of having nice rectangular vertebrae that are stacked, they have a wedge vertebra or hemivertebra that creates scoliosis. That particular curve is probably not best treated with bracing, but sometimes if they have a thoracic congenital curve, they may have a lumbar curve that's compensatory, that's not congenital, but in response to the thoracic curve. That lumbar curve can be braced. Having said all of that, there are some patients that are young and they're going to grow a significant amount that occasionally we will brace congenital curves and really test that sort of paradigm that you can't brace congenital curves. So I think there's opportunity, and I think this is an institution that looks at the traditional methods and sort of for each patient really delivers a custom-made care plan for that patient. So if you have a young child who has a congenital curve and has a compensatory lumbar curve, we'll try to occasionally brace both those curves because we want to prevent them from getting any bigger.
Okay, I think we have one more question left. So one of the last questions was talking about what degree of curvature would you recommend starting this kind of treatment? I mean, I know that they come in for a screening,
Yep.
But is it a certain, I know you talked about a certain kind of curve or degree to even begin this
Yep.
process?
So that's ultimately the question that folks want to have. So for idiopathic scoliosis, generally speaking, curves less than 20 degrees in children who are growing or if they're done growing, generally speaking, curves below 50 degrees don't ever need treatment. So in a skeletally mature patient, let's say a 16-year-old boy, 14 or 15-year-old girl, and we will have ways of looking at x-rays and asking important questions about how much growth they have left. If they don't have any growth left and their curve is less than 45 degrees, generally speaking, they won't need any treatment. In a growing child, if their curve is below 20 degrees, we'll watch that patient. If they're above 20 degrees, then and they're still growing, remember curves get bigger if you're still growing fast, then a brace is a really effective tool. And we have a couple different types of braces, and it depends on the curve magnitude. It depends on the curve, where the location is of the curve. So thoracic curves are more common than lumbar curves. And we have two types of braces we have several types of braces, but two main types in terms of whether they need to wear that all day and night or just the nighttime brace. So curves above 20 degrees, we really start thinking about braces. Certainly curves above 25 degrees, almost automatically get a brace because we can really hold that curve to a small magnitude, and generally they'll wear that until they're done growing, and it will hold that curve in that spot, and then they won't ever have any troubles into the future, won't ever need surgery, and will lead a normal life.
Awesome. Thank you so much for joining us today. I think that wraps up our Facebook Live.
Well, it was fun. Thanks for having me.
Yes, and so if you have any more questions, you can put it in the comments below or visit our website.
Thanks, everybody. Have a great Friday.